I want to talk to you about our EHR journey. And I was thinking of a title for this, sort of after being identified as EMR Stage 7 and Meaningful Use Stage 2, kind of what title would I have? And I actually thought maybe given that I stayed last night in Anaheim, it's sort of, so you've achieved Meaningful Use Stage 2 and MRAM's Stage 7. What are you going to do next? I'm going to the Nixon Library. So this is an interesting place. We were reflecting on, there's a sort of occupational hazard with CIOs that you have a large ego to begin with, and this does seem in front of the presidential seal and doesn't work on very well with us. Let me tell you about what I want to cover over the next 45, 50 minutes. I'll give you a little bit of one slide on the legacy overview, sort of the pictures and the numbers. I want to talk to you about our EHR journey, which we called Third Time a Charm. A little bit about how we steward that through our clinical informatics program and our accomplishments, namely the Stage 7 of HIMSS and Meaningful Use Stage 2. A little bit about what's on our radar screen, and then the last thing is what keeps me up at night. So here are our pictures and numbers. We are an Oregon-based health system in Portland, Oregon, so Portland and Southwest Washington. You may know Oregon, our state. One, it's pronounced Oregon. You're in California, so would know that. But we're also well-known to have the only state exchange that could not register anybody online. So we are with the federal exchange. Heard the news yesterday that Oregonians are signing up through the federal exchange. Of course, we are in a lawsuit with a California-based database company that we sort of blame for that, but that's another story and another presentation all to itself. Kind of our numbers from 1 to 100 million. We have 6 hospitals in the urban Portland, Southwest Washington, Vancouver area, 1 children's hospital, 2 regional referral medical centers, and then 3 community medical centers. We have a number of primary care sites. I mean, very similar. I loved following Memorial Care. A lot of the strategies and even the geographic expansion that you're doing here with Memorial Care is similar to what we're doing at Legacy. I think of interest is that last statistic, $98 million. We had a $100 million budget. We came in 1 month early and $2 million short. Rare in an EHR journey to come in under budget and early, but did. As I said, our EHR journey was a three pitch. We started many years ago. Legacy itself started in 1875 in the Portland area. We started basically from an electronic health record perspective, IDX last word, that we began really at the turn of the millennium in 1999 when we went live with that system and really powered our environment for well over a decade. About 12 years we were on that. In 2005, we opened Washington State's first greenfield brand new hospital. So it's called Salmon Creek in Vancouver, and did that as a digital hospital and worked with Cerner, which had been our lab for many years, as this slide shows, and did a Cerner enterprise-wide system. At the time, we had a new CIO who was also a physician, and led us into a journey of, well, what are we going to do? We had at the time 2 EMRs. We had IDX at our 5 Oregon hospitals and Cerner in the Washington one. We're looking at the possibility of sort of moving and really called the question, asked ourselves, what direction are we going? And realized that our strategy as we all are in healthcare, moving to ambulatory care, moving to sort of an integrated system, that we needed a system and a partner that would work with us around a fully integrated system. So very similar to Scott's graphic of that, one large, I think it was orange, your centerpiece. So we started looking at EMR directions and decided to go with Epic. How many people here, actually, I'm interested in the audience, how many work at a health system? Wow, just our speakers. And then how many are vendors who work in the space working with us? Okay. So just get a feel for who I'm speaking to. Epic has been a great partnership for Legacy Health. It's interesting, they have a very strong culture, which they're known for. We spent 2 years doing the design and build, and that I think was very important for us for our successful go-live. They really wanted us to move faster, and they're an amazing learning organization. So past failures or past missteps, they really build into it. And one of the past missteps was these design, build, validate sessions that would go on for a very long period of time. And sort of Epic's thing is just go live and optimize it. And we pushed back and did a 2-year design and build, and then implemented across all of our system over the course of a year. As I said, Mount Hood was the last. It's a community, one of our community medical centers, and we wanted to get live in September so that we could start with the Meaningful Use Stage 1, which began federal fiscal year, September of 2011. Successful rollout, as I'll mention in a minute about our HIMSS Stage 7 journey. But let me talk a little bit about what we've done for clinical informatics. So you have an electronic health record, but how do you continue to maintain it and continue to drive forward the goals that you have for an electronic system? Our goal for clinical informatics at Legacy is this: to optimize patient outcomes. That's the end of the day, patient outcomes and care delivery through a deep integration of both information and technology into the practice of clinical care. We are led, and I have the slide later, our informatics program is co-led by a dyad, a chief medical and a chief nursing informatics officer, who lead this program. The primary functions that we have put into our clinical informatics program are these: to do the strategy around clinical technology and information adoption, to guide our continuous optimization. I think I've been involved in a number of EMR implementations, and the sense that you celebrate at the go-live is soon washed over with the reality that that is just the beginning, not the end, although you take a break and you let your people go on vacations for a little bit of time. But you come back, and just like the Golden Gate Bridge, you just continue to repaint from one side to the other. It was interesting, as Scott mentioned earlier, we have a shared experience that gap between what's released and what we have implemented can get higher and higher. And Epic is realizing that and putting a lot of attention to making sure that the things that are released, people are adopting and using. And our clinical informatics program is for us, the one that leads that. Meaningful data and analytics. So, we don't want the EHR system to be a data roach motel where data go in and never come out. And so we're really looking at trying to do a lot of business intelligence, and I'll talk about that. And then an ongoing review of documentation to, one, ensure just compliance, but also that we improve user efficiency. Our clinical informatics, our CNIO, talks a lot about the nursing practice, like if I don't document all this sort of thing, if I don't take the time, the 38 minutes to do the documentation, or 38% of the time to do the documentation, then I'm not doing the best patient care. I'm not living up to the best principles of my industry and my training. And she's like, no, you want to be hands-on to the patient care, and let's do documentation only when it makes sense. And then finally, training and support, which is a very large ongoing part of what we do. How are we measuring success for our informatics program? As I said, we went live with Epic through 2010 and 2011, and I joined Legacy. I have the pleasure of being there since 2012. And we have a fairly mature informatics department, which I'll show in how sort of both the governance of it and as well as the staffing. And we were looking at, what's sort of the next generation? So now that the EHR is over, our physician informaticists, what's their job? What do they do? How are we measuring success? And how does this become an ongoing business, an ongoing division of our organization? And how do we measure success? So we talked to Gartner researchers and the like, and really wanted to say, kind of what's out there? What are the best practices? What are the emerging practices? And to find that we're kind of all in the same boat. I wouldn't say we're on the bleeding edge of it, but the questions that we were asking Gartner was saying we're not hearing from many of our partners, our customers, because you really want to make this a true department. It's a department of 45 people, and I want measures of success. So we chose these. We're continuing to work on them, but the important indicators of, at the end of the day, as I said, we want to optimize health for our patients who the EHR is not a destination, it's a journey. It's a way to get to the better outcomes. And so we measure patient quality and safety as part of our informatics. Of course, you know, it's a multi-factorial equation. EHR is only a part of that. We're measuring patient involvement through what we call My Health, or powered by Epic MyChart. Access to notes. The Portland community has chosen to do the open notes movement as a whole community, so every health system in the area has agreed to open all progress notes to all patients. We are heavily dominated by Epic in our marketplace, and so doing that through MyChart. We're putting our money where our mouth is, so we have a program at Legacy called Strive, which is, there's an acronym that I can't remember off the top of my head, but it's a $1,000 opportunity for every employee, the 10,000 employees of Legacy, depending on our performance. So that's financial performance and quality. But this year we're measuring MyChart activation to be a part of it. So $250 of the $1,000 bonus opportunity, and then all of our management incentives are driven by getting to 78,000 patients signing up for MyChart. We are a ways away. So if anyone wants to sign up for Legacy's MyChart, I have a laptop. The clinician adoption and satisfaction, and we measure this. We use the advisory board to be our physician engagement and our staff engagement survey, and we measure how that satisfaction and adoption is. Meaningful use is a great word, but what I really want to do, the goal for us, the measure, is that we are actually meaningfully using an electronic record while also achieving meaningful use payback. As I said, we spent $100 million in capital for Epic, and we have forecasted to get $40 million of that investment back through meaningful use incentives. And that pretty much, as I talk to my peers, about a 40% reimbursement, but it certainly spurred a lot of the country to adopt electronic health records. And then finally, compliance. Compliance is a measure of success. We have a governance structure that really recognizes that this is an ongoing commitment, an ongoing clinical operational lead of our electronic health record. It is a clinical tool. I mean, we are the IT people that support it. Clinical informatics works in between IS and our clinical and operational partners, but they really need to stay at the table and ongoing create that collaboration. The other thing we've attempted to do, and other organizations I'm sure have, you heard that from the CEO of Memorial, that we saw Epic also as an opportunity to look at standardization of care practices and care programs across our 6 different healthcare venues. And so how to lean the system and learn from innovation at one organization, but then diffuse that through our organization. Informatics governance helps with that. So kind of how we're organized, we have an IS governance function that I have the privilege of chairing. It's really our CEO and the executive group is on that. It's sort of the same players with some additional ones from our executive council. We have an IS governance structure, which is actually just the 5 of us. So it's the chief medical officer and the chief nursing officer and I as the CIO, and our CMIO, CNIO, and we really steward these things through advisory councils and specialty user groups. The specialty user groups are, I mean, this is kind of classic of how Epic sort of recommends and sort of best practices, but it has worked really well. On the specialty user groups, we make sure we have nursing and physician care team, where it makes sense, pharmacist and other members of the care team. So it truly is an interdisciplinary direction for that. They may look at something that spans the clinical practice across the organization, and that goes to our advisory councils that are at the higher level. But for all intents and purposes, I could take each of those green squares and put an Epic product name, because they're really product leading of that. We also do the same thing on revenue cycle, so making sure that our completely integrated information system is working well. I'll finish on this overview of clinical informatics with just a talk. That's our organizational chart. The CNIO and CMIO work for me, but are also dotted line to our chief medical officer and chief nursing officer. I remember when I was CIO at Providence 3-4 years ago, there's a lot of, this is a very controversial, it wasn't controversial to me because I didn't really care. I worked with a CMIO at Providence who said, if it matters what line, who your line report to, that is an emblem of a greater problem. So for all intents and purposes, these people are, they are clinicians working within our clinical operation that happen to be within our IS family. The gray is the traditional IS, and the blue is informatics. As I said, we have a dyad leadership there of CMIO, CNIO. The CNIO does not work for the CMIO, which was also the course of a lot of conversation. That works well, although that's a tension point at all the times, because it's really, sort of two to agree, and sometimes they don't always agree. So it's fun for me to watch as they go through that. As I said, they're both dotted line to our clinical leadership. We have 3 FTE, but it's 10 positions, 10 people, 10 individuals that range from a 0.1 to a 0.7 that work with us. We also have principal trainers, mostly nurses, but we have an RT and a pharmacist who are principal trainers. We have EHR clinical experts that continue to go around. We had more when we went live with Epic, and group medical students who were scribes during our go live. And they go around and just continue to help and do at-the-elbow support. But 12 nurses, and specifically the job requirement is nurses that do remote phone support, different than our IS help desk. We have a clinical, the EHR support center that can remote in to any of the workstations and help. It's been a big investment, and I've talked to a lot of people about sort of post, when you're in the post EHR, kind of how are you staffing it or whatever. And prior to my getting there, although we've continued to perfect it, the organization said, we're making a $100 million investment in the electronic health record. We can't just sort of plop it in and then run away. Truth be told, we sort of did that with our ERP system and are paying for it, one of the projects I'm working on. So benchmarking our success, just 2 quick slides about kind of external benchmark of what we've done. One is that we have achieved the EMR adoption model stage 7 system-wide. Legacy was the first system in the country to achieve that, so across all of our clinics and all of our hospitals. And Scott Jocelyn was our CIO on-site evaluator. I love this program. One, it's HIMSS, which is our professional society, but also it is a designation that requires an on-site accreditation. So unlike others that are self-reported, and we were very nervous, as Scott remembers, as we walked around our clinics and our hospitals to see the dearth of paper to prove that we have achieved the highest level of EMR adoption. They noted a number of things, the governance. So as we completed the evaluation, the governance structure, sort of the use of analytics, health information exchange. I'll mention in just a minute about care elsewhere and care everywhere that we do. And a number of very significant amount of device integration that we had, and barcoding. We were barcoding not only medications, but also breast milk in our delivery center and blood products. The other one that I'll make a comment on is meaningful use stage 2. So we have achieved at all 5 of our hospitals meaningful use stage 2, and we attested in July. So as you can see, this is from Wells Fargo. I love his meaningful use dead. Well, pay the money out first and then kill it. But before July, so in the first I guess the third fiscal calendar, there were only 10 hospitals that had attested, another 63, this is out of 6,000 US hospitals. That Epic line that has the 21, Legacy represents 5 of those 21. And it was very tough, and I'll talk a little bit about why that was really tough in what keeps me up at night. But we're also doing so we did eligible hospitals. We're now in the process of eligible providers as well. Really very difficult. The meaningful use stage don't need to tell you, it's been good that we have attested and we're down that way. The other thing that's interesting of having so few people attest, the federal government is auditing the attestations, and they had a limited, they had the budget to do select audits. Well, we are now 49 concurrent audits right now of our prepayment meaningful use stage 2 audits, because the auditors didn't have much work to do because there weren't a lot of attestations. So it's kind of a colonoscopy for us. Without the prep, at least. So I'll stop there. Strategically, kind of what we're working on, similar to kind of what you hear. I'll talk a little bit about population health myself and my need to sort of soothe myself around population health and what it means for IT. But similar to kind of all the organizations, our first major area of strategic focus is to optimize the electronic health record. And again, like I said, that's a means to an end, not an end in itself. And the end that we're striving for is driving excellent clinical quality and patient outcomes through our electronic record. Remember a physician at Providence, when Providence was making the decision about which enterprise electronic health record to go, and a physician said, what we really want the electronic health record is to drive out human error that is inherent in our system. And so if you could have the safety valve of a system, a smart system, that could drive out human error and human variation, needless variation. We also want to motivate active patient engagement. It's the patient. The definition of engagement is that they need to do it, but have tools and systems and promotion that motivates that for better health. Transform care delivery and reimbursement. It was interesting. Barry, the CEO of Memorial, saying, I have a foot in the canoe and a foot on the dock. That feels a lot more stable than I feel today. It's more like 1 foot in one canoe and 1 foot in another canoe. At least the dock is fixed, so 2 canoes moving a lot. And so, sort of how do we succeed in a payment that pays for volume when we want to do pay for value? And so in pay for value, you try to get people to not use your system, but in this kind of living in two worlds, that's very difficult. Legacy, unlike our competitors in the area, we are very much a community health system. We have 2,800 physicians on our medical staff, but only four are employed. Only 400 are legacy employed physicians. So 2,400 members of our medical staff are community physicians who have private practices and their own electronic health records. And therein lies some of the complexity with population health, that we're actually trying to come together as a clinically integrated network to present sort of this geographically diverse and specialty diverse community of health providers, sort of like Vivity, although it's only one hospital. So powering our clinically integrated network with information, when that crosses geographic boundaries, it crosses legal and ownership boundaries, and crosses technological boundaries. There's a huge complexity. We want to deliver population health. Epic is doing stuff, and we're working on Healthy Planet and other work with Epic. But for all intents and purposes, the electronic health record is not around a population, it's around a person. It's you're caring for the individual patient, not a cohort of patients, and therein lies some of our complexity. And then accountability. So how do we don't have a health plan, although we're talking about what is our future in that space. Unlike our big competitors in the area are Providence Health and Services, that in the Oregon region has a health plan, and Kaiser. Empowering decision makers through business intelligence. I remember a story, meeting with a chief medical officer around, what is our goal around business intelligence? And we're in a meeting, it was great. He was he's now since retired, but a real driver for a clinical improvement and data and analytics. And a phenomenal physician. And we're in the meeting, and I'm talking sort of, well, we need to develop a BI strategy, which is sort of you and me. 20 minutes into the meeting, he stopped me and he said, oh, now I get what you're talking about. I thought when you said business intelligence, it was about espionage about our competitors. I'm like, no, although, that could be interesting. That what we're talking about, of course, is analytics and clinical intelligence. We work, as I said earlier, within a community, an ecosystem of healthcare, which more and more for like our Medicaid population includes behavioral health people. It includes the churches and other places where people get health information. For the young, it's their friends. And so how do we engage that entire ecosystem through information and intelligence? ERP, revenue cycle, medical grade infrastructure, and also to work at the bottom of these, the three are sort of the infrastructure, the core. We have to run a system that is incredibly reliable. We have to do information security that inoculates us from the bad world that's out there, and we have to maintain compliance. Compliance, of course, will come up this year with potential meaningful use 3 measures into next year, but also ICD-10. I have had our CDIP, our Clinical Documentation Improvement Program leader, is doing a bet saying she's pretty convinced ICD-10 will not happen this year. So it'll be interesting to see. I'm just please make it go. Do it. We were ready last year. Do it. Those are sort of our strategic aims, but let me fly by sort of what's on our radar screen for this next year. Just a huge amount of work. So, if Epic produces it, we're launching it. We went to a users group meeting a couple of years ago I went with our chief medical officer and chief nursing officer, and we were sort of overwhelmed and impressed with all the things that Epic is coming out with. I mean, and how much we could benefit from that. So as we've done our informatics governance, they prioritize individual physician or nursing requests for changes. But in reality, I mean, it's like, yes, that's a good direction. We will always do sort of the bottom-up, how do we want to change? But, Epic has 8,000 staff and 3,500 programmers that are making that. We could never keep up. So what we've done, this fiscal year, we're going to do 2 upgrades back to back. We went to upgrade to 2010 last April, and this next March, 2012, and then this March, we're going to go to 2014. So within 11 months, 2 major upgrades of Epic, a stressful amount of work. But not to let any stone unturned, we're also not only upgrading Epic to 2014, we're going to implement Willow Ambulatory Pharmacy and Healthy Planet and Epic Phoenix Transplant for our transplant program. A lot of patient engagement. We'll be doing MyChart Central, which facilitates a good experience of users who have multiple MyChart accounts. We are going to move into Get Well network for patient engagement at the inpatient side. We do a very extensive Community Connect program, HIE. A lot of business intelligence products, and then just kind of the business of our organization. We're going to do an Infor upgrade, but just kind of being a staff person, being a physician, so how do you securely text to your colleague? How do you get on the schedule so we know what hospitalist is working when? Time and attendance, we, like many organizations, have screamed into the 1980s of technology, and we use phone to clock in and out for 10,000 employees, and we'll be moving to barcoded-based or swipe-based time and attendance, upgrading our IS customer service and doing regulatory. Finally, a number of things are just around the infrastructure, a lot of life cycle replacements. So I hear the same energy that your CEO tells you, Scott. We spend of basically our $20 million a year capital budget, about $7 million is spent just in life cycle replacements, whether that's PCs or old networks and the things like that. Our core phone switch now, we're getting parts from Romania because there are no more parts in the United States that cover it, so we are going to replace our phone switch. And then Windows Windows. Next year, we will be moving to Office 365. So we're moving to the cloud and PACS virtualization. A window into what we do in IS and sort of our goal. So the last driven really by the organization, with that last exception of the infrastructure, but kind of how do we measure our success and what are we doing? Our vision as an organization, the vision for legacy, the mission is our legacy is good health for our people, our patients, our community, and our world. And so we wanted to connect what we do to our overall vision. We are grounded in our mission, vision, and values, but in IS, beyond that, we also have IS competencies, IS culture, how we treat each other, how we come to work, don't steal a lunch if it's in a refrigerator, that sort of thing. IS structure. Another, a positive unintended consequence of working with Epic is you get a glimpse to how they acculturate, about 1,000 23-year-olds every year, and have a really powerful way that culture is self-referencing and self-growing, and we want to do similar things. In terms of our goals, it's people. It's our people. It's our people in IS and informatics, so highly engaged IS staff and highly satisfied customers. And I will share with you about the measure we do for how we're doing. Our lean measure is number of vacancies, because a vacancy really means harder work for the people around who are trying to make up for that vacancy. So what keeps me up at night? Generally I answer the question, when this is a vendor, so most of you, ask the CIO what keeps you up at night. My quick answer is, vendors asking me what keeps me up at night. Keeps me up at night. But here for you, because you've paid to be I will share with you, the CEIOs, what keeps me up at night. And I'll start very petty, I have to admit. It's not Epic with all caps. And if I'm in a specifically ornery, I've never received a message that is that crass that we have got great Epic talent that we steal from the mothership. But if they spell it with all caps and they say, we've got really good Epic talent, every once in a while when I'm just in a foul mood, I've had a bad meeting, I'll reply back and say, do you know that my measure of whether you really do know Epic is if you can spell the company's name right. I used to do it with Meditech when I was at Providence because people would not spell Meditech in all caps, which it is. So kind of petty. So another thing that keeps me up at night that's an interesting kind of, I don't know how to solve this, is sort of the achievements we've done from an electronic health record are actually more recognized externally than by our own folks, which of course leads to the CIO opportunity to find another job. So it's something it does keep me up at night. For us, we have an incredible number of things to be proud of. As I said earlier, we're the first health system to achieve stage 7 everywhere, all hospitals and clinics. 11 sites this last 2 months ago, 11 sites, 11 organizations were accredited by Epic in doing Community Connect, and Legacy is one of those 11. We have a very important strategic growth in hosting Epic for others. And we're one of the first 11. We're one of the first 73 hospitals to attest for meaningful use stage 2 in that quarter, April, June. And then of Care Everywhere for HIE, we're in the top 2% of Epic customers, exchanging message volume between us and both Epic and non-Epic. We were an early adopter and influencer of Epic products, their cardiology suite that is now called Cupid. Anesthesia, home health for our hospice and transplant. The interesting part of this, so as I said, what keeps me up at night is kind of the barriers to internal marketing. And I kind of reflect on these. One is there's really an underappreciation from our CEO and our board and of really what it takes. So as I call this is the home front CIO syndrome. My CEO is incredibly tech savvy. Wireless network at home. Brand new. Anytime the iPhone anything comes out from Apple, he has it at home. It works flawlessly. It's like okay, now that I'm my own CIO at home, I realize this is a lot easier. What the hell are you, why does it cost so much and take so long? And I'm like, oh, thank you, Apple, for the consumerization of IT. But really, there's sort of an underappreciation. Yes, it took you one day to, upgrade to Windows 8 at home. We have 14,000 workstations, so multiply that day, we'll get back to you in 14,000 days. There's a tendency in our field, certainly in healthcare, to avoid self-promotion, other than you might think of where I am standing up here, that there is a tradition of humility. I might not be exuding right now, but there is a tendency to, sort of avoid self-promotion, certainly at legacy. It's also a hard message to craft. I remember getting the meaningful use, getting the EMR adoption model stage 7. I mean, that's an amazing accomplishment. Fewer than 1% of US hospitals are at that level. And going and selling, I mean, they produce, HIMSS does great, beautiful plaques. They're glass. They are now in every lobby of all of our hospitals. But delivering that to the message when they're like, still sucks. I mean, so to sort of declare victory when we, physicians are like, I'm still staying an hour later to do all my notes, it's kind of hard to say, at least let's pause to celebrate. And then the other thing is, this is the life of IT. You finish one thing, and then you're on to the next new project. That whole project list that I showed is a testament to that. So, how to do good internal marketing that isn't too self-aggrandizing, but also, reflects the sadness I have is not me. I mean, I soothe myself in the middle of the night. It's the staff of our 300 people who were really working extremely hard to deliver these things that I want to do it. Next thing that keeps me up at night is customer delight. I love your equation that you used for project management, but I actually think it's a measure of customer delight, because the fewer unplanned projects you have, it means you are really well respected by the customers. So to me, that P over U plus P is a proxy for customer delight. We measure it with our physicians. I said earlier, advisory board is our physician engagement. There are two questions that they ask. One is the hospital pursuing an effective EMR, EHR strategy? And generally, our group was, our physicians were, the respondents were fairly happy. Higher, 15% higher than the benchmark from advisory boards. So I tend to agree, strongly agree. But the next question is, does it help you? Do you have the information you need to assess your productivity and care quality? As you see, we're sliding down. And that's kind of Epic's. If you look at KLAS report on Epic, their black eye is data warehousing and business intelligence, and our lived experience is the same. What I want is the democratization of business intelligence. Your universities were doing the same sort of thing. Get information in the hands of people who can just mine the data as they see fit, rather than have to wait for reports and all that sort of thing. Certainly a huge strategy of ours, and this is a big one. So the disagree and tend to disagree, those are disconcerting numbers when it's your productivity and quality. We should be giving hands to the caregivers. Our CMIO looked at the qualitative. So, physicians chose a number and then wrote a lot about their feelings about our system. And they kind of came into these 14 themes. I won't go through all of them. But a lot of it was just around the support, the training. With our 2012 upgrade, we had physicians back. We decided what we would do is every other upgrade, we would have physicians back, sort of butts in seats, so back to do training. And it went okay. We didn't have physicians do the training all the time, so there was a lot of complaints, and that one around value the provider's time. If you're going to have me in a classroom for 4 hours to redo Epic training, sort of get remedial training, then make it worth our while. A lot of what we did at that last training was train them on meaningful use, after visit summary documentation requirements so that it would meet EP requirements and ICD-10. Well, yes, we had to do it, and as an organization that's important, and compliance and the like, but it was a lot. Extracting data, getting data out of it, decreasing unnecessary work, more computers and access, scribes, fix radiology orders. Yeah, a lot of stuff we're doing. So against that backdrop of the user satisfaction, then who's going to do the other thing keeps me up at night? Who's going to do the work? And we talked a little bit about the difficulty in recruiting and retaining talent. We use a lean board, so lean methodology, so make it visual, measure what matters and make it visual. And as I said, one of our goals is engaged employees. And the proxy we're using, the trailing indicator is sort of our vacancies. And so let me tell you what every Tuesday, I missed it today, but it goes on even when anyone's not there. Our management team huddles around a board. We measure customer service scores that have come out of our remedy system, and any score that is lower than a 3 gets a yellow dot, and more than 3 of that gets a red dot. And we talk about it. We do a customer recovery for every call that has poor customer service ratings. On employees, we kind of worked on the measures a lot. Green means I'm fully staffed. Yellow means I have 1 vacancy. Red means I have more than 1 vacancy. And we were originally like 1 to 2 would be a yellow, and the frontline managers are like, if I have more than 1 vacancy, it is devastating my work. I'm paying all my attention to hiring and interviewing and working with human resources, and not the care and feeding of my customers and my people. So we're going to make it a red dot. As you can see, it's difficult to hire in some of our areas. Look at business intelligence and data services. So critical to our future. It is what the doctors said as our complaint. Red dot generally through the entire zone. We have staff augmentation, a vendor here who is helping us fill that gap, and thank you for that. But a lot of need. The other measure of this, so this is our vacancies, but what about the workload? So we use Microsoft Project Server. This is a heat map for the 2015 projects that I showed you on those prior slides, and how we're doing. Blue means good. Blue is it's a heat map. So red means areas where we are significantly under-resourced. Doing a PACS virtual VNA system. I mean, our diagnostic support services is really overextended. So a lot of demands for people and hard to fill, and we are in an epicenter of Epic, and so there's poaching between the organizations, and haven't lost a lot to consultants, but certainly a lot to each other. Meaningful use, so I call this, I've always relied on the kindness of strangers. The burden for us for meaningful use was it was out of our control. The transition of care required that our trading partners were on direct messaging or had an HIE strategy. We do not have, Oregon does not have a statewide HIE. And then the portal measures. So while we're doing great on quality and all these other, CPOE and all this sort of thing, the meaningful use stage 2 upped the ante for kind of what our healthcare system has been wanting to do since I joined it 27 years ago, which was be able to exchange information between each other and have patients engaged. Transition of care was the reason we couldn't attest earlier, was we didn't meet the threshold for the transition of care. 10% had to go electronic to a non-legacy system, and that was a barrier until the direct messaging was adopted by a couple of our other key training partners. Nasty world out there keeps me up. And who the hell heard of ransomware until you watched The Good Wife? If you saw The Good Wife episode, you're all in Los Angeles, you're part of the industry. And so we've had 2 computers blocked by, you ever heard of ransomware, where they take over they deliver malware and then send you the message saying, we've taken over your computer, send us, please put your credit card number to free up your computer. Information security, so big topic, and it does keep me up at night a lot. We require, HIPAA, high tech and meaningful use requires that you do an annual risk assessment. We alternate between doing it internally and doing it with external expertise. And external expertise, we alternate between different companies, so we don't kind of we get the value of different perspectives. So this last year, this November 3rd, Leidos Health, with the cybersecurity arm of SAIC, did our assessment with us. As I said, we have 49 eligible professionals that are being audited, and now the audits are asking for, they're deep audits, and they're asking for your risk assessment, but they also want to go back 3 cycles and see that, okay, you've done the risk assessment, but actually are you doing things that are improving your risk? So if you knew that you had this patient potential HIPAA breach risk, what are you doing about it? So they're getting a lot more, the federal government's getting a lot more intrusive in this. We have shown so we had Deloitte do the 2012, we did the internal in 2013, and the validation in 2014. We're moving better in a lot of areas, so less red, more green. Business continuity management is the #1 that has been red for a long time, and that does keep me up at night. You can't really see this, well, you can, it's Google Directions. The walking direction from our enterprise data center at the top of the screen and our backup data center 6 blocks away. If you could see the slide, which you'll have in between, so you know how Google highlights different businesses, sort of that I don't have a pointer here, that white building that is pretty much the white center is a brew pub in between the two. So it's often a detour stop between our 2 data centers. But this map, so this is right in the sort of north side of Portland. If I zoom that map out of the data center, so where we have the core one and the backup one, is the seismic map of Portland, and that little box square is right there next to the red 10% in 50-year earthquake. Now, if it's beyond 10 years from now, it'll be my successor's problem, which is why I labeled this slide my successor's worry, because if it goes down, he'll have to mop it up. I'll be fired. But we're working on it. Other things, security threats. You probably are aware of the community health system, the for-profit, Tennessee-based company that had the second largest HIPAA breach of 4.6 million records. And to hear the story of that and how just persistent, it was effectively, Pearl Harbor from a foreign state terrorism organization that went after CHS just persistently for a very long period of time. I know no way that I will protect our organization from that kind of thing. Got through phishing and then planted, malware into the organization, but didn't exploit it immediately and just left it there as a ticking time bomb, and then exfiltrated this, Excel spreadsheet with medical records. They say that the one medical record is $50, a medical record number and all the identifying, healthcare identifying protected health information. Information is a $50 on the black market, and a social security number is like $9. So we are in for state organized crime and state affiliated. Phishing is a very significant worry for me because it's the lowest common denominator. It's basically your information security is as best as a paranoid recipient of email. We did a penetration test and tried, and did spear phishing, which is targeted towards leaders whose email is likely in LinkedIn and all that sort of thing. And 10% of people who received a thing that said, your email box is full, please put in your credentials to open it up, 10% of the recipients did it. And so then my last kind of what keeps me up at night is, we spent 3 years and $100 million on an integrated electronic health record, and my partners in crime are easily distracted by the shiny new population health and the like. And so the comment I would make in terms of this sort of post-electronic health record, I love that concept of it's table stakes. I mean, now after if meaningful use did, I mean, I was Providence's CIO at the time, and if you remember, meaningful use is actually part of the ARRA money, and the economy was going down, and I just remember talking to the CFO. It was like, we're going to have to significantly retain capital. We're going to take all of our money out of the stock market and put it. I mean, it was just 2008 was bad economic times, and from an IT perspective, it's like we're on these very old systems. We need to be moving into the modern era, and how quickly literally within 7 months, the dialogue at our organization went from we have to restrict capital and we're not going to spend anything. We're certainly going to use our legacy systems to the best possible, to a wholesale. For Providence, it was a $1 billion implementation of Epic. For legacy, $100 million. We spent all this money, and now it spurred the economy. I mean, I'm so pleased. Meaningful Use has done an incredible amount for our industry. Things that we've been talking about, standard adoption and health information exchange. And as we're looking now at the rearview mirror, our EHR implementation in the rearview mirror, we've been thinking, okay, what's post-EHR? And for us, it was, use it and share it. So business intelligence and health information exchange. What's interesting, and it would be funny to look at Scott's graph of the quilt of information systems that you have to weave together, what that looks like 3 years after Vivity goes live, or for us, our clinically integrated network. So we've been doing investments and implementation for BI and HIE. Tall order, hard to hire people and all that sort of thing. But the net new right now is this whole, what I call the sales angle around population health, managing risk, and a clinically integrated network. We're going to have a clinically integrated network, we have, called Legacy Health Partners, that's going to have people who we want to treat as part of, that whole video about imagine. My imagination is, okay, what are you going to spend on the IT to do that? When the ambulatory care clinics that are part of our clinically integrated network are using eClinicalWorks and GE Centricity and Aprima and just name all the EMR. Epic is, yes, dominant in the hospitals in Portland, but not at all in the medical groups. And how do we do population health and engagement? I certainly don't want to do it out of the medical record, but that's my fears. We're going to do, risk-based kind of registries and population management. So let me look at all my high-risk diabetics who are not being treated well. Well, ultimately, yeah, I might explore that in a Crimson data cube that looks nice with graphics and colors, but ultimately I'm going to have to engage the patient, and engaging the patient is in the electronic health record, and I don't know how to do that. And certainly the salespeople who are wooing my colleagues aren't talking about the dirty underbelly of what this will do to, literally your plan of going from this disparate hodgepodge of electronic health systems into an integrated system. We spent $100 million doing it, only to walk away from it is my fear. And so I don't know what our industry will do, and I don't know how we'll do it, and I don't know what Epic will do. And so the whole population health, it's fascinating. This keeps me up at night the most, because we are excited with our colleague physicians who want to join that journey with us, and I think they should, and I think it's good for the patients. But how to do that electronically, literally abrogating a strategy that we spent a lot of time and a lot of money to do a integrated electronic health record, only now to disintegrate that across geographies and care venues. That's not a really uplifting ending of what I wanted to say, but open to questions. It's sort of like I said, our journey has been very, very successful. A lot of people. I'm here representing 300 people in IS who did that, and 10,000 users of our system, and 8,000 people from Epic. So thanks.
Hey, thanks, John.